Good evening, everybody. This is just a little housekeeping as people are joining in. This webinar will be recorded and will be available on our website for future playback. Also, if you have a question, please use the Q&A icon to type it in, and I will ask it during the Q&A session at the end of the presentation. So thank you for joining us tonight for this engaging and educational talk with Dr. Michael Stubblefield. Dr. Stubblefield is both the Director of Cancer Rehabilitation for Kessler Institute and the National Medical Director for the Untitled Cancer Rehabilitation Program. He is also the architect of comprehensive cancer rehabilitation programs for Select Medical's national network of inpatient rehabilitation hospitals and outpatient therapy centers. To sum that up, Dr. Stubblefield specializes in cancer rehabilitation. Dr. Stubblefield's clinical expertise is in the identification, evaluation, and rehabilitation of neuromuscular, musculoskeletal, pain, and functional disorders resulting from cancer and its treatment, particularly those caused by radiation and neurotoxic chemotherapy. Dr. Stubblefield is triple board certified in physical medicine and rehabilitation, internal medicine, and electrodiagnostic medicine, and has published extensively in medical journals. Thank you, Dr. Stubblefield, for giving this presentation. Now I will turn it over to you.
Wow. Thank you for the very nice introduction. And I'm seeing very nicely that there's 188 people out there. So I welcome you all. And I can't see any of you, so I'm going to try to keep you from going totally bored and as we go through this. So this is kind of a fun talk for me. We're going to go over lymphedema. We're going to talk a little bit about radiation fibrosis and some other issues. And ultimately, we're going to use this as a springboard to talk about some of the latest and greatest treatment options. So a few disclosures, first of all. I have a textbook that you're all invited to go out and purchase if you need something really heavy to hold your door open. I am on the scientific advisory board for Tactile Medical. And when I'm not pretending to be a doctor, I'm a photographer. So all of the photos that you'll see in the presentation from mine, hopefully it'll make it just a little more lively. That's a tough and puffin for anybody who's keeping score. All right, so we're going to start with a couple of poll questions also to keep you engaged. So our first one is just to get a sense of our now 201 people out there who's in the audience. So hopefully you guys can click on who and what you are. And if you're in a big group watching this, so far nobody's chimed in yet. I'm beginning to think it's me. Okay. So still haven't seen. Oh, there we go. Okay, finally we're starting to get. Okay, now it's like watching one of those little races of the subway trains at Yankee Stadium. So it keeps going up and down. All right, we've got a while to go here. A few more seconds. Although I can't really tell how many seconds. Great. All right, so what we're looking at is about half of our audience, and I guess I could have guessed this, are physical therapists, around 20% occupational therapy, around 20% CLT. We've got some SLPs, we've got a nurse practitioner and a nurse navigator. So welcome to all of you. So what we have here is a very comprehensive group of rehabilitation clinicians. So awesome. All right. So this is the double-crested cormorant to start us into what is lymphedema. And I'm going to guess for a lot of you, you have a pretty good idea. It's this abnormal accumulation of protein-rich fluid in an extremity, trunk, face, breast, back, genitalia. It can literally be anywhere in the body. The real important thing here is this protein-rich part. It comes into play in a big way as we kind of go through this talk. Now, how do you get it? Well, very simply, your ability to clear the lymphedema fluid is inadequate to take care of the load of lymphedema fluid that's coming into an extremity. And that often, at least in the United States, occurs as a result of surgery, radiation, or other cancer treatments. In other parts of the world, infections like filariasis are very common causes of lymphedema. So some fun facts, right? Caused by disruption of lymph transport. It can be primary or secondary. So lymphedema praecox for very early onset in infancy or childhood lymphedema. Lymphedema tarda can come on later on. These are, relatively uncommon disorders, but if you're in the rehab world, particularly if you treat lymphedema, you're going to see them. Again, I cannot overemphasize that this is protein-rich fluid, and this is really what differentiates it from peripheral edema, which we'll talk about in a minute. It can cause swelling in any part of the body. It can be acute and then go away rarely, or it can become a chronic disorder. It can become permanent and disfiguring, leading to contractures, skin breakdown, a variety of other issues. And it's a huge cause of social, emotional distress, lowering of quality of life, lowering of function. So lymphedema versus peripheral edema, sort of first off, just because it's swollen doesn't mean that it's lymphedema. This is a very common mistake. I see. I get a number of patients swollen. I had one, a couple of weeks ago. She had swelling in the eye, and it was probably a parotitis that was actually causing it, and not actually lymphedema. They were treating her for lymphedema with some benefit, but that wasn't the diagnosis. So lymphedema is really this increased interstitial protein as well as higher pressure in water, where peripheral edema, the big difference is it's a low protein state. This is something you get with heart failure, renal failure, fluid overload, that sort of thing. And the lack of protein has importance in sort of the pathophysiology, the progression to fibrosis, which becomes the later stages of lymphedema. The risk factors, well, so much of what we see is in the cancer world, so surgery, breast surgery, axillary lymph node dissection, pelvic surgeries, gynecologic surgeries, colorectal surgeries. Tumor itself very commonly can do it. Infection and the scarring and inflammation of lymphatic can do it. Gaining weight or just being overweight can do it. As you get older, things start wearing out, including your lymphatic system, so age can contribute. Trauma can contribute, and chronic venous disease can also contribute to lymphedema. Now, I'm going to take a little tangent from the lymphedema discussion to something that's very near and dear to my heart, which is radiation fibrosis and radiation fibrosis. The reason is these are so often linked in the patients that we're going to see. And while it's important to separate them, it's also important to understand how they interact. So a couple of definitions. Radiation fibrosis is the slow, insidious tissue hardening that we get as a result of radiation treatment. Radiation fibrosis syndrome, all the bad things that happen to you as a result of the radiation fibrosis. So the nerve injuries, the lymphedema, the tightening of the tissues, the secondary cancers, the cardiac disease, are all part and parcel of radiation fibrosis syndrome. I'm going to talk about this a little more when we get to head and neck in here. Determinants of radiation fibrosis, well, there's several. Radiation we call the gift that keeps on giving. So the radiation's out of your body immediately after we treat you, but the damage it's done to the DNA continues to cause tissue abnormalities, which lead to the abnormal deposition of fibrin and other proteins. The fibrin is a normal protein in places where it shouldn't be. It'd be like if I started filling up this room with bricks. Pretty soon, bricks are normal building material, but it becomes a little bit dysfunctional in here. And if you cut yourself off from your blood supply, you die. So the things that contribute to radiation fibrosis are the total dose of radiation, the size of each radiation treatment, other oncologic treatments you've had, like surgery, the patient's sort of protoplasm, their overall health, somebody with diabetes or a rheumatologic disorder, the tissue. So lung is very sensitive to radiation and nerve is relatively resistant to radiation. And then time. The longer we go, because this is the gift that keeps on giving, it's not unusual for patients to start manifesting radiation fibrosis 5, 10, 20, 30. I have some 50-year-old past treatment survivors, and it just gets worse indefinitely. It's kind of an immortalized process. So another poll question. So which tissue is likely to be affected by radiation? Got a few choices here. Let's see how you guys do, keeping everybody awake.
And Dr. Stubblefield, I'm going to jump in here right now. We've got some feedback that you're a little staticky. So
little staticky. All right. So what I'm going to do is I'm going to stop my sharing just so that I can actually, let me see if I can switch my microphone. So I'm switching my microphone to the webcam. Is that better?
Say a couple more words.
Can you hear me now? Can you hear me now? Is that better?
I think that's better.
Okay, good. So
All right, thank you. So now that means that anything that goes on in the apartment, including my wife sitting here working next to me, you guys are going to pick up. So sorry about that. Of course, we have no dogs or kids, so at least that won't be a part of it. All right, so how do we do on our poll question? Awesome. So yeah, so everybody, you know, most of you got it. The truth is all of the above. They are all likely to be affected by radiation. Which one is more sensitive to radiation? I think you guys are kind of right. It's between lymphatics and lung, but the truth is all of these tissues can be affected by radiation. All right. So morbidity from lymphedema. Well, range of motion limitations. Patient earlier this week, you know, new visit for me with, you know, her arm moving just through, you know, 10 or 20 degrees of range from her lymphedema and the fibrosis that's in it. Pain, absolutely. I don't believe the lymphedema really damages the nerves per se, but it certainly causes pain through other issues. Fibrosis is a big one. That's why we added the radiation fibrosis part of this. Stiffness, weakness, loss of function, the cosmesis, it just looks terrible. And, you know, in addition to everything you've had with the cancer, the psychological distress, ulcerations, infection, and rarely lymphangiosarcoma, which I've never seen in my career, but I think that's partly because we are getting better at managing lymphedema, although we're certainly not perfect. All right, so we'll talk about clinical evaluation a little bit. That's a manta ray for anybody who cares. And before we do that, I think it's important to use these striated caracaras that are very good at working together to talk about sort of our role. So with lymphedema, we all have a role of diagnosis and treatment. And as part of the Revital program, our National Cancer Rehab program, I've been a huge advocate. We've really managed to build a team of PTs, OTs, and SLPs for the evaluation and management of cancer patients across the spectrum. So me as a cancer doctor, my job is to kind of diagnose these things, optimize these things. I do a lot of pain management. But the PTs, the OTs, and the SLPs are really the hands-on managers of lymphedema, but they also are the ones who will often say, oh, Dr. Stubblefield, you know, she's getting a little swelling or something, and kind of cue me into something that I may or may not have seen. So I consider this management of lymphedema and the diagnosis of lymphedema very much a team effort. So for the physicians particularly, but really everybody out there, there's a lot of things in the differential. DVT, cellulitis, tumor recurrence is a big one that you need to kind of exclude. Tumor recurrence, particularly in somebody who develops lymphedema, 2, 3, 5 years later, you worry about. The higher the stage, for instance, of breast cancer. If you have a stage 3 breast cancer and they develop lymphedema sometimes later, you should really be worried about if tumor recurrence is possible. Fracture, right, of the upper extremity, complex regional pain syndrome. I've seen it rarely, but I've certainly seen it. Vascular insufficiency. I'll see this commonly in like Hodgkin lymphoma survivors who get this, and less commonly, but I've seen it in head and neck cancer patients who can actually have large artery and vein occlusions. Renal failure, cardiac failure, interestingly, myxedema, like very low thyroid, is when you see, and remember, head and neck cancer patients, Hodgkin survivors, because of the radiation, often become hypothyroid. I would actually go so far as to say usually become hypothyroid if they've had radiation that affects the thyroid gland. And lipedema, which we're not going to talk about, but kind of keeps company with lymphedema, and then of course vasculitis. So in terms of the history, right, you're looking for these risk factors. I'm a big stickler for really understanding the patient's cancer history from A to Z. It's not enough to say it's a 65-year-old woman with breast cancer. I want to know which side, where was the diagnosis, how old she was, the stage, the receptor status. You want the surgery, complications of the surgery, the revisions. You want all of that to really fully understand this patient and put them into the context of what's going on with them. So those other conditions that we just kind of listed, if they are contributing, it's important to understand. Ruling out malignancy cannot be overstated. And then, of course, again, part of our Revital motto of not just providing comprehensive care, but providing care for all of those impairments the patient's likely to have. So if they show up with lymphedema, they also may have shoulder dysfunction and aromatase inhibitor arthralgias and mild cognitive impairment and chemotherapy-induced peripheral neuropathy. So we want to know those other issues so that we can address them as well. So the physical exam, certainly a comprehensive neuromusculoskeletal exam, heart, lungs. We want to know about their pain, their functional issues. We want to know what kind of condition their skin is in. And we're going to do some measurements, right? If you're lucky out there and you have bioimpedance, that's great. A lot of us are still using tape measures because those are relatively expensive interventions. You want to look for pitting and the consistency. You certainly want to look for skin breakdown, erythema, any evidence of infection now or in the past. Hemosiderin you can see deposited in the skin. And then some special exam findings. You know, the edema spares the NTPs and stemmer sign where you can't pick up the skin on the toes. Now, for me personally, I guess, you know, I look at all of this, but the truth is for me, if it looks like a duck and it walks like a duck and it quacks like a duck, it's probably a duck, so long as the rest of the medical stuff isn't giving me a reason to believe they have lymphedema. So I'm looking for that history of cardiac dysfunction and renal dysfunction and hypothyroidism, those other things. Once they've kind of cleared that hurdle, and we don't have a good reason for the lymphedema, then I'm usually going to call it lymphedema. I'm not going to do lymphoscintigraphy or any other sort of specialized test to confirm it for sure. Grading. So I think it's important to grade lymphedema. Grade 0 is a subclinical. The patient may just feel some heaviness. By the time they're grade 1, they're pitting. They'll usually reduce a little bit with elevation as they go into grade 2. The edema still may or may not pit, but they really don't reduce with elevation. And now you're starting to see some fibrosis. And by the time they're grade 3, they're really talking about elephantiasis. We'll show you some pictures of this where, you know, it has a very distinctive feel to it. You really aren't able to get a lot of motion, that sort of gelatinous feel that you get in the earlier stages. And everything is hard and sclerotic and bound down. Imaging, right? I talked about lymphoscintigraphy briefly. Again, I don't do it because I don't think it's necessary for the majority of patients. Some physicians who do this would argue with me over that. For me, it's about the tumor. So I'm ordering MRIs with gadolinium. Here's somebody with lymphedema and a big recurrence in the brachial plexus, CT with contrast, PET CT. And I know this is mostly lymphedema therapists, but there's sort of a logic for how do you roll these out. And if you have a high suspicion of cancer recurrence, you often have to redo these imaging periodically until you find it. Thromboembolism. So it's another one. It's relatively easy and expensive to get a Doppler to rule out DVT. So when I get a new patient with new onset swelling, I will usually do the Doppler as well as the usually an MRI with gadolinium or a CT of the chest. And then cardiac, right? You can usually tell if somebody's at heart failure on other clinical exam things, but when in doubt, an echocardiogram really helps you with that. So those are baby Barnes-Wells for anybody who cares. All right, so lymphedema treatment. Again, I can't overemphasize that these are piping plovers, a nice endangered species, that everybody has a role in both the evaluation and the treatment of this. For the physician, my job is to make sure it's not mixed edema and to make sure that, you know, it's not their heart failure and to make sure that they don't have a tumor recurrence. But for the PTs, OTs, SLPs out there, you all have a role to play, not only in the lymphedema, but really for me to emphasize all these other functional issues that these patients may have. And working as a team is absolutely critical here. So the pillars of lymphedema intervention, well, number one is education, right? What is lymphedema? How did I get it? Did somebody screw up? Why did they tell me this would happen? Which doesn't happen so much in breast, but happens a lot in head and neck cancer. Let them understand what the signs and symptoms are and what symptoms they should be reporting. Any risks or precautions that they should be taking for the lymphedema, how to manage it at home, and what their therapy options are. Then usually these patients are going to be referred to a lymphedema therapist who's going to go over some in-depth education, teach you how to do the wrapping, try to set you up with a proper fitting garment, and, you know, serve as sort of a touchstone for this. Now, once they get home, a lot of patients will do okay, but they need to be compliant with their exercises. And this is one place, at least more in my treatment, I've been incorporating the Flexitouch, which we'll talk about more as we go through the presentation here. And it's very important to note that the NCCN has actually issued survivorship guidelines that do talk about lymphedema. One of the critical points for me here is that lymphedema begets lymphedema. So if you can identify lymphedema in those early stages and manage it aggressively, it not only decreases their symptomatology, it may actually help mitigate the progression of that lymphedema to a more severe stage with more severe functional impairment. So because of that, I think the screening for swelling and heaviness, fatigue, and all of the other things that come along with lymphedema becomes progressively more important. And again, for any patient who's not being well managed with that, considering pneumatic compression for the ongoing home management, I think becomes very important. And I've been ordering a tremendous number of pneumatic pumps, many more than in the olden days when I first started, because they were basically 3-chamber pumps that were like kneading dough. But now these multi-chamber, 36-chamber pumps really do a very, very good job. So the goals, well, there's no cure for lymphedema. It's kind of like old age. You're never going to get younger. The lymphedema wants to get worse. Radiation fibrosis also wants to get worse. So it's about managing and optimizing the patient's function and quality of life with respect to the lymphedema. So we want to reduce and maintain the lymph volume. We want to minimize this fibrosis. And a big point here, why I brought up radiation, is radiation fibrosis is a fibrotic process. Lymphedema is a fibrotic process. We really can't do anything about the underlying pathophysiology of the radiation fibrosis, but if we get out the lymphedema and minimize that process, potentially we can slow the progression of the patient's issues over time. Restoring and maintaining skin integrity, preventing infection, making them look better, addressing the psychosocial issues, and of course, minimizing the neuromusculoskeletal dysfunction that comes along with the lymphedema, as well as other treatment. So primary treatment options, elevation and early stage will work, but certainly isn't our best thing. Manual lymphatic drainage or complex decongestive therapy, where this is a major component, is one of our primary treatments. Absolutely compression with bandaging, a compression garment. And of course, now I think pneumatic pumps are becoming much more commonplace and important in long-term management. Exercise. So interesting, not just aerobic exercise to maintain fitness and weight level and keep your weight down, which is important here, but there's excellent, level 1 data that progressive resistive exercises not only minimizes the risk of developing lymphedema in women at risk, but if you have it, also is a major component of treating lymphedema in these patients. So exercise is really important here, just hard to do, but that old dogma of don't lift more than 20 pounds has really been disproved as a lie for these patients. Skincare education and some newer treatments, acupuncture, low-level light therapy seem to have some role, although we can argue about the studies of those later. All right, nice little Adelie for you guys, Adelie Penguin. All right, so breast cancer-related lymphedema, it's still common, right? Even though our surgical techniques have improved over the years, and they become less morbid, we still see lymphedema in about 30% of patients, depending on what was done to them. If you've got axillary lymph nodes positive, it's much higher. Truncal edema is extremely common. And this has a huge cost, right? It increases their, decreases function, increases infection, causes psychosocial issues, and it's expensive to have lymphedema. It's expensive to treat it, but it's probably more expensive to have it. And there's still a lot of gaps in our care, right? We don't identify it early enough. If we do identify it, we don't treat it early enough. And a lot of patients cannot get state-of-the-art treatment for lymphedema. A lot of patients can't even afford the sleeves that go along with lymphedema. So we still have a long way to go with respect to optimizing our care in this group of survivors. So some patient characteristics that are at high risk. So early swelling, right? This comes up a lot. Oh, I had post-operative swelling. Does that put me at risk for lymphedema? I'm thinking now is, yeah, that probably puts you at risk for lymphedema, and we should deal with that. High BMI. So patients who are obese are higher risk for lymphedema. Positive notes, the more you have, the worse. 4 more gives you like a 10-fold risk of developing lymphedema. Taxane-induced chemotherapy seems to be a risk factor. Patients who are ER negative seems to be a risk factor. And of course, radiation is a huge risk factor that we've known forever. Patient symptoms, again, this is just a checklist. I'm a big believer in these sort of patient-reported outcomes. This one, I don't know entirely validated, but it certainly will clue you in to somebody who may have lymphedema. So anybody who complains of any of these really needs to be looked at closely. I think, again, because identifying lymphedema in the early stages is key to treating it early, aggressively, and minimizing its progression in the future. So trunk lymphedema, this is another big one, right? I remember surgeons telling me, oh, they don't get lymphedema, in the chest wall. I'm like, in my opinion, almost all of them get lymphedema, and that's actually backed up by the more contemporary research. It can be on the breast, which is most common, in the axilla, and really back, onto the back. Any part of the chest wall can be affected. And it's relatively, straightforward to diagnose there, but people just need to really look at it. Again, the stages, stage 0 or 1, potentially we can reverse the symptoms, minimize the progression, improve their quality of life. Once they move into that fibrotic stage, stage 2, they may have a little bit of reduction with elevation, because these are a continuous sort of line, but it gets a lot harder. So we're really trying to minimize the symptoms and help maintain or improve their quality of life. And late stage lymphedema, there's limited things we can do because that fibrosis is set up in there like concrete, but still we really want to do everything we can to improve their function and quality of life. So, a bit about the Flexitouch, again, our sponsor tonight. This has been a tremendous device. You can see, the number of chambers in this thing. They have a head and neck, and they're only one with head and neck. It's actually very comfortable. The patients love it. So, they're able to do this when they're often not able to do the bandaging. This is particularly important for patients who have functional limitations to trying to do the bandaging, which can be, kind of complicated, relatively convenient. It's very comfortable. It decongests stuff that would take you a long time to do manually. You see it going on the chest and trunk up to the abdomen here. And there's actually pretty good data behind it, which we can't say for everything we do in lymphedema, and more data coming out all of the time. Chipmunk, who's waiting for its next drink at the bar, as best I can tell. All right, so the clinical evidence, right? So this is just kind of showing you an arm here, right? Elbow and wrist. And this is after they've tagged this protein here. And then you can actually see that protein starting to move up the arm with the lymphedema. So the whole idea is it's not just getting rid of the fluid, it's getting rid of the fluid and protein, that concrete that we don't want to set up and lead to fibrosis. And it does this with these very just small little inflations that stimulate. It's not like you're sitting there trying to knead dough, right? It's a very gentle, those of you who are lymphedema therapists know, it's butterfly level touch to try to get these lymphatics to move. And you start proximally and you work your way distally with the inflations. So, the evidence, right? Patients are better able to self-manage. So this is just a 14-day look in some of these patients after treatment. And you can see that the volume reduction was much better with lymphedema than just self-MLD. And the patient's weight was also, quite a bit lower than with, the standard MLD. So looking here, we have kind of a mixed cancer, non-related cancer. My big interest, is mostly the cancer population. Well, look, huge reduction in cellulitis for both groups. Big reduction in outpatient visits, big reduction in hospitalizations, and that lowers costs. So this is cost effective, right, relative to the other things that we're doing, right, particularly doing nothing in these groups. But even versus our standard MLD, as we can see from here, which just isn't as effective once the patient goes home. You can be the best therapist in the world at getting, lymphatic, fluid to move along with its protein, but once the patient goes home, they're kind of at their own device to keep it. We all know they don't always do very well. All right, so head and neck cancer. That's a black-bellied whistling duck, one of the cutest ducks in the world for anybody who cares. So our next poll, how many head and neck cancer, or do you guys just treat head and neck cancer? Ooh, okay. Nice, okay, I'm getting, yes is winning. Yes, currently is winning. And it's fun. I can see we're up to 237 participants. So I wish I could see all of you guys. These virtual talks are just harder and harder to get, but the bird photos help. All right, nice. Yeah. So 2/3 of you guys just about are actively treating. About 20% treat, but not all the time, and only about 20% don't treat. So that's terrific. It is a specialized population. So to that end, let's talk about this specialized. One of my personal favorite things to treat are radiation late effects. And of course, lymphedema is a huge component of that. But these head and neck cancer patients, I think, are a special group. They're getting a very high dose of radiation into a very small, important area and end up having a lot of complications. Tends to be an older group, although now with HPV, we're getting them younger. So they come to the table with these baseline comorbidities. And then what do we usually do first? Well, not always, but usually we operate on them. So now they're ending up with a spinal accessory mononephropathy. Their shoulder isn't working well. They've got neck spasms. They're having trouble opening their mouth. They've got dysphagia, dysarthria. They've got nerve pain. And of course, lymphedema that maybe even started depending on where the tumor was before they went to surgery. Well, then they get chemotherapy and radiation, usually combined. Now, risk for CIPN, less in this group because we don't use as much. The doses aren't quite as high. But if they do, they get gait dysfunction, ADL impairment. Certainly now fatigue, particularly with the radiation, starts creeping in. We can start getting cognitive impairments in these groups. Their lymphedema gets worse. Their dysphagia, dysarthria can get worse. Well, now they ring the bell. Everybody's happy. I finished my treatment, right? And they're into sort of the survivorship and surveillance thing. And you can see red kind of denotes worsening of their signs and symptoms. Which a few months later, this is just kind of arbitrary, I just made this one day to kind of illustrate this point, they start getting better. And that may go for a year, 2 years, 5 years, and all of a sudden, these other issues start popping in as a result of radiation, the gift that keeps on giving. So one of the terms I coined is this nervous system damage to the spinal cord, the nerve roots, the plexus, the peripheral nerves in the field, like the spinal accessory nerve and the other cranial nerves, and the muscles in the field. And I've coined this term myeloradiculoplexoneuromyopathy, say that 5 times fast, right? Some of them will get dropped head syndrome or just neck pain or neck spasms. They get osteonecrosis of the jaw, right? Depression and anxiety, suicidality is very high in this group. Their trismus can start getting worse now, usually in the first year, but it can become later. They're kind of getting into their tumor recurrence time. Their lymphedema, worse still. Their dysphagia, dysarthria, worse still. Their dropped head syndrome, worse still. Their shoulder dysfunction, worse still. So these patients really become kind of a hot mess. So the reason to point this out to you is if you're just treating lymphedema and they're referred in for that, look around. You're going to find a whole lot of other things that we can really do to help these patients. All right. So, there's a huge number of lymphatics in the head and neck. About 1/3 of the body's lymphatics are there, and many of them, a big quantity of them, are right in the field of fire of radiation. These head and neck cancers go to the lymph nodes, which is where the lymphatics are. It's their little, Grand Central Station, if you will, right? And the signs and symptoms of lymphedema, the things it keeps company with, are the swallowing problems, right? Lymphedema probably is a contributor, other than just the neuromuscular damage, to dysphagia. It contributes to the pain, the sense of tightness and discomfort, right? The lymphedema, again, like the radiation fibrosis, is a fibrotic process. The range of motion starts getting restricted from the radiation and potentially from the lymphedema. The tightness can make them feel dyspneic, short of breath. They'll have swelling, importantly, both internally and externally. That internal lymphedema is part of what's contributing to the breathing and the swallowing problems. And now that we're looking more at it, we see it's there pretty much in everybody, right? So my assumption with head and neck cancer patients is if you have head and neck cancer and you've had treatment, you have lymphedema. And it's usually very easy to prove just by pushing. But I think if you just make that assumption until proven otherwise, you're going to be right in this population of patients. So here, young woman, relatively mild lymphedema, but you can see how she's starting to lose, and you can start feeling some of the brawniness of the skin. When you touch it, it has a different consistency, and to test something that doesn't have lymphedema, something outside of the radiation field, and you usually feel the difference. Somebody getting slightly worse lymphedema, and then here. And these would all be like almost mild to moderate lymphedema. This poor guy's got more severe lymphedema. You can see all of this internal swelling, and you can imagine how that affects this patient's ability to swallow and breathe and talk, right? And you can imagine all this lymphedema through the neck, rooting a proprioception and their other issues can contribute to their cervical dystonia and their spasms and everything else. So in my practice, I've been basically giving Flexitouches to everybody. After kind of our get acquainted, because they come in and I find 20 things wrong with them, and I start working on the primary issue first, and then I incorporate this in, largely because not to make them prettier, right? But I think it's to try to help with all of these other issues that they're having. I really don't care nearly as much personally about the cosmesis. I know some of the patients obviously do, but I'm very concerned with the dysphagia and the dysarthria and the cervical dystonia and the trismus and all of these other things. And any little bit I can get to treat it in this complicated group helps. So this, I believe, is the only pump approved for head and neck lymphedema in the United States. Patients usually wear it 32 minutes a day. I have a couple patients who do it, twice a day, some who might do it, 3 or 5 times a week, depending. Great egret, for anybody who cares. I really like that shot. I didn't know I liked it as much as I do, but I do. All right. So this is a study, I believe, out of Vanderbilt. I have a very good relationship there. One of my former residents did a fellowship in cancer rehab and is now the cancer rehab doc down there. So she's very involved in these studies with Barbara Murphy. But, looking at the Flexitouch versus self-management, swallowing solids, 4-fold improvement, pain stayed stable in the Flexitouch patients, but increased over the course of this study in the self-management, and external swelling, of course, got better, as you would expect. Now, this is a small study, but it's sort of a beginning of the proof of concept as we move towards bigger studies. This study is one that I've actually been really very impressed. Carolina Gutierrez out in Texas, who's another person I've collaborated with quite a lot, who's just doing excellent work. So you look here, your ability to control the lymphedema at home, much better with the Flexitouch. Level of breathing, better, significantly better. Head and neck pain, better. Swallowing, this is an important one, right? Because some of these head and neck cancer, they're all important. But, I have several patients a year who have to get a PEG because of the dysphagia, because of pneumonia. I had a call from one earlier today who's one of my head and neck cancer survivors, who's been sort of on the edge, went on vacation, fell, hit his head, had a cerebral hemorrhage, ventilator, ICU, and guess what? They can't get the nasogastric tube out of him, and he's going to have a PEG. And I was talking with his wife about it, again, because of the radiation. So every little bit that we can do to prolong their need for the PEG, to minimize the risk of aspiration, I think becomes incredibly important for these patients' function, quality of life, and overall health. And then, of course, the lymphedema's interference with daily activities goes down. So I run through this much faster than I thought I would. I think we're near the end. So we'll have plenty of time for questions. So my big thing is, when do you incorporate the Flexitouch? And the answer is, it depends. So for me, I'm a cancer rehab doc who does see some patients before their treatment, some patients immediately after, but mostly I get patients when they've had problems sometime after their treatment. So I have to, because there's always so much going on, I have to strategize about which intervention I'm going to roll out first. And usually I'm setting on, if the head and neck cancer patients, they're going to go to PT for the cervical dystonia and for all the myofascial manual techniques. They're going to go to our OT for the lymphedema, and they're going to go to the speech language pathologist for the dysphagia and the dysarthria, and we'll do a modified barium on them, right? So having done all of that and maybe started them on a nerve pain medicine, right, it's not necessarily the time for me to roll out the Flexitouch, but certainly within the first few months of me seeing the patient is when I start broaching the conversation. Now, if they show up and their big thing is lymphedema, I can lead with it. But I think as we know more about this pump, we are going to start moving it earlier and earlier and earlier into the rotation of treating these patients, for the simple reason that we want to minimize the number of complications coming by decreasing the fibrosis that goes along with the lymphedema. All right, I guess I talk fast like a New Yorker, although I'm actually in New Jersey. So with that, I'm going to stop sharing, I believe. That's me with my gigantic camera that I carry around to get these bird photos. And I'll let the good folks from Tactile come back on and straighten us all out.
Yeah, thank you, Dr. Stubblefield. Great talk. We do have some questions that have come in and I've been keeping track, so I'll just go through them on my list, and feel free to keep adding your questions if you have them. So the first one that I have is there a way to test levels of plasma protein to determine lymphedema versus peripheral edema?
That's a great question, and the answer is I don't know. Right, I think it's really, I don't think in clinical practice there's a way to do that I'm aware of. The most sort of definitive test for lymphedema would be lymphoscintigraphy, where you can see if you're getting dermal backflow and you're looking at the sort of distribution of labeled protein, but measuring the actual protein content in the tissues outside of a sort of research environment, I don't know that we can do it. If there's somebody in the audience who knows other, then please chime in.
Okay, well, I'll go to the next one. When do you see an incidence of CRPS with lymphedema? Is it due from a surgical procedure like microsurgery to correct lymphedema?
Yeah, so that's interesting. So complex regional pain syndrome, reflex sympathetic dystrophy, the sort of autonomic driven pain syndrome is relatively rare in cancer in my experience. I've seen, hundreds and hundreds of lymphedema patients, and I can count on one hand the number of times that I've seen RSD or CRPS in this group. And I believe it's usually related to a surgical trauma that's not necessarily the breast surgery, but some other thing that happened to the patient. So I think it's relatively rare. I have not personally seen it in relation to breast reconstruction, but if you have one out there, then it wouldn't surprise me. It's just not something that I have personally seen.
Okay, thank you. The next question is, in one of your slides, you stated air travel, venipuncture, and blood pressure cuffs do not exacerbate. This person's training indicated otherwise. Yeah,
exactly. We got a lot of dogma. Right. So a lot of the stuff we used to say in lymphedema was because Dr. So-and-so said so, right? So that the precautions to not lift weights, for instance, was because this is what people said. It just wasn't questioned very much until Dr. McKenzie up in Canada got all of his patients in these dragon boats and realized they're actually getting better and not dropping dead of their lymphedema. And then we had studies backing it up. The question of lymphedema damages nerves. There was a crummy study showing that lymphedema caused brachial plexopathy that was from the 70s. When I was at Sloan Kettering, I had the privilege of doing a lot of EMGs on patients with lymphedema, doing them bilaterally, both the conductions and the needle. I was actually able to go back retrospectively, and my conclusion from that supported that was not the case. And I think with venipuncture, air travel, it's probably the same thing. Anecdotally, we see patients who their lymphedema is precipitated by these things, which I believe is different from causing these things. So is it prudent to wear a sleeve? Yeah, okay, but I don't routinely give it to my patients for air travel. A lot of the lymphedema therapists out there, because you learn it, are going to, and I'm not going to argue with you over it because I don't think it's that big a deal for them to wear a sleeve. But what I think happens is that if you're on the edge of getting lymphedema, and the negative pressure, dehydration, whatever it is of being on an airplane causes you to get it, you are going to get lymphedema. That was just the insult that allowed it to precipitate. And I think it's the same thing with venous puncture, right? If that little tiny bit of inflammation locally is going to cause you to get lymphedema, you are going to get lymphedema. And there's some data out there backing that up. But a great question.
Here's a question. Any suggestions for getting the MD buy-in for lymphedema treatment? Some breast surgeons I've worked with do not refer until patients are in stage 2 and have even said that lymphedema is a myth.
Yeah, so getting the MD buy-in, was that the question?
Yeah.
Yeah, slow, steady pressure. it's an ongoing challenge. It's the same thing for us when in Revital. We're mom and apple pie, and I think we do great things. And we have trouble, it's a constant struggle to get physicians to refer appropriately. So I think it's showing up at the rounds, giving them patient examples, talking about how happy the patients are, making it easy for them. So you got to look at the world from the point of view of an oncologist. Some of these poor folks are out there seeing 30, 40 patients a day. They're not able to spend a lot of time. They don't want to sit around talking with you about lymphedema, right? When what they're trying to do is make sure patients are getting the chemo on time and their counts are okay and they're not going to die of an infection. So it's not a slight on the doctors. They're just really overworked. So operationalizing your treatment with sort of standard order forms for assessment that don't really affect them in terms of their workflow adversely or cause any additional work for them is absolutely critical. So, going in and having a heart-to-heart conversation is good, probably not going to work. Making it easy for them and having examples and showing them that you're actually going to decompress them from work, that is going to be much more effective.
All right, thank you. Couple patient-specific questions. When can a head and neck patient, for example, laryngectomy, start lymphedema management after the surgery?
Yeah, immediately, right? So if they have postoperative swelling and the wound is healed, then I think it's appropriate to start. The surgeon is going to, it's usually 2 to 4 to 6 weeks, depending on sort of the surgeon's tolerance for being able to put any pressure. Now, remember, the pressure from this thing is butterfly light. It's really not a lot of pressure, but the surgeon, it's really that wound healing that's kind of your first issue. And I don't know that it's critical to start it in most patients in, the day after surgery. If you wait a few weeks, that's probably fine.
Can skin-sparing mastectomy patients develop breast lymphedema?
Say that again.
Can skin-sparing mastectomy patients develop breast lymphedema?
Can what type of mastectomy? I missed the first.
Skin-sparing.
Oh, skin-sparing mastectomy. Thank you. Yes, absolutely. Right. So yes, you're still disrupting the lymphatics. Just because you're peeling the skin back and taking everything out doesn't mean that you haven't perturbed the lymphatics. They get post-mastectomy pain syndrome, they get lymphedema, they get the whole works. That's a great question.
Here's another question about patients. In a head and neck cancer patient, I see severe shoulder scapular weakness, even when the op note says SAN intact. Is that possible? What could be the possible reasoning for this?
Because they're retracting the SAN, right? It's always damaged. So two reasons, right? When we look at studies of the spinal accessory nerve, it's and you do EMG studies, there's a few of them out there. It's almost all of them are damaged in the course of the surgery. Just there and there, they've got everything pried open. It's a hot mess. So that's just from the surgery. But remember, then we radiate them, right? So we seal the deal if they had some dysfunction by giving them 70 gray of radiation, right exactly where that spinal accessory nerve runs, which is in sort of the same bundle with the lymph nodes. So, it's one thing to see them immediately after surgery before radiation, but then once you do the radiation, you're almost everybody gets some degree of trapezius weakness as a result of that.
Here's one. Do you take baseline circumferential measurements of head and neck and shoulder range of motion and functional strength measurements before treatment?
I don't, because I rarely see them before treatment, but I think those are great things. If you're doing a prehabilitation program, or what I like to call a PROHAB, prospective rehabilitation program, then absolutely, I think it's a good idea to have those baseline measurements. It also helps you justify your treatments going forward, and it gives the patient some data that they can work with as well.
Do you have any advice for speech language pathology students interested in working with this population?
Yeah, absolutely. So I think it is critical for the SLPs to one, kind of know and own the full spectrum of issues that happen in the head and neck cancer patients. So meaning you're not just worrying about their speech and their swallowing, but you want to get involved in the trismus. You want to learn some manual techniques. you actually want to learn how to do lymphedema, because that's something that, depending on where you are, it's great if you have a PT or an OT who can do the lymphedema and you can work on other things. But if you don't, marrying those together may make you more effective in your treatment, and just understanding that knowledge base is going to make you better. Understanding the mechanics of the shoulder is going to make you a better speech language pathologist. Understanding, the effect of core on mouth opening is going to make you better. So, my advice would be learn all you can. There's the ACRM, American Congress of Rehabilitation Medicine, is really kind of PTs, OTs, SLPs, and physicians, has a lot of programming on cancer rehab. I can't even tell you what I've been invited to give some talks on this, but there's a number of talks out there that talk about, head and neck cancer rehab. It's actually becoming kind of a hot topic. So avail yourself of that information. You'll become an even more amazing SLP.
How do you differentiate between post-surgical edema and lymphedema? Often patients continue to still have their swelling tagged as post-surgical after months.
Yeah, that's a great question. You can't, right? So if the swelling is continued months after, it's probably starting to grade into lymphedema. So that was one of the slides we were talking about. That immediate post-operative swelling seems to be a risk factor for the development of lymphedema. So you may see this thing where they get a big bump in the swelling, it gets better, and then kind of starts coming back later. That probably graded from post-operative swelling with lymphatic dysfunction to absent post-operative swelling, now just lymphatic dysfunction. So I don't think there's any, to my knowledge, any gold standard test for that. I think at a certain level, if the patient has post-operative swelling, it's okay to treat it. And if it's continuing later on, I think it's probably graded into lymphedema.
A question about radiation fibrosis. Is there any medication management to lessen the fibrosis?
Yeah, great question. Short answer, no. So pentoxyphylline and tocopherol. So pentoxyphylline is something we use for like vascular claudication. It has some neurohormonal effects, but mostly I think about it as it lets the red blood cells fold into a little tighter thing to squeeze into the capillaries so you can get into more nooks and crannies. And tocopherol is basically vitamin E, which is considered to be an antioxidant. So there's some studies that came out of Europe, multiple studies on this, each one worse than the next, showing efficacy of this. And they keep pushing back the time. Doesn't work for 3 months, doesn't work till 9 months. Now it won't work for 2 years. My personal experience has been that they really don't do anything useful. So if somebody's put the patient on them and it's not causing any issue, like the pentoxyphylline cause some GI upset, then I have no problem with it, but I'm not endorsing it. And none of the other medications, unfortunately, have been shown. My completely uneducated hunch is that at some point we're going to figure out which components of the cascade that causes fibrosis are important. And we're probably going to have targeted monoclonal antibodies to help heal the process that may not reverse but may slow radiation fibrosis. And I say this just because our whole world now is about these monoclonal antibodies, migraines, right? We have anti-CGRP, antibodies, and cancer, these immune checkpoint inhibitors. They're just everywhere, and it seems to be the rage of the future. And I'm hopeful that something like that will come along to help with radiation fibrosis.
Does your team have therapists embedded in the surgeon's and oncologist's office? How do you get buy-in from the patients to show up for their therapy?
Yeah, great question. And the answer is yes, in some places. So we've got over 1,000 therapists for Revital working in, 400 or 500 markets, or centers in like 20 or 30 some odd markets. I can't even keep track. So in some places, for instance, in Texas, where we're very tightly aligned with Baylor Scott and White, and some other private oncology groups that are like US Oncology, we've managed to show our value to them and be able to actually create our own clinics inside their clinics and have direct referrals. We have a number of clinicians who are really bought in. And literally everybody, you need to have a chest x-ray, you need to have a CBC, and you need to have a rehab evaluation before we take you to breast surgery. So we have a number of them are like that. And again, it's slow, steady pressure. The more successful you are, the more likely other people are to kind of join. And, you know, our values, we're trying to say, you know, we're going to help keep your patients from bothering you. We're going to make them happier, but we're going to save money by keeping them out of the ER, out of the hospital, keeping them on their oncologic treatment, you know, and the ones who buy into that really, which I think, you know, is valid, really embrace what we have to offer.
What are your thoughts on internal lymphedema impacting the esophagus? Current literature demonstrates a pattern of esophageal narrowing in head and neck cancer, and we are seeing improvement in other,
Yeah, so you said it, right? You know, my level of expertise there is that internal lymphedema affects everything, right? It affects voice, it affects swallowing, it affects respiration. And my sense is that treating the lymphedema externally, particularly with the pump, will actually help mitigate, you know, even that internal lymphedema.
And speaking of the pumps, there's a question: do you see any long-term risks of using Flexitouch?
No. Yeah, I'm basically, for my patients, I've been using it on several for years now. And I think this is just a way of stimulating the lymphatics and decreasing the flow. So I don't see personally any potential downside. I have trouble even theorizing what the downside would be to that.
And the second part, which I'll answer, is, you know, should the pumps be serviced? If so, how often? And the Flexitouch has an impressive life, and servicing and maintenance isn't really needed. We rarely see malfunctions, but if there is any sort of error code that pops up, you can give a call to Tactile Medical and they can figure it out. The next question regarding Flexitouch, there's always a question about, is it covered by insurance? Are there options for uninsured patients? So Flexitouch is covered by most commercial payers. For the head and neck, unfortunately, at this time, it is not covered by Medicare. But if a payer doesn't approve Flexitouch, Tactile has cash pay options, payment plans, and patient assistance programs, and we'll do what we can to help patients get what they need. Let's go for the next question. Let's see. There's a lot of them here. Do you have recommendations for how to chat with doctors to increase early referrals to therapy for prehab as a part of early surveillance? I've had multiple docs be unaware of this model or indicate their surgeries do not cause lymphedema.
Right. The second part of that first, yeah, I've had so many doctors, you know, tell me that it doesn't cause lymphedema, and you're seeing these patients who look like chipmunks. So yeah, how do you talk to a doctor? It's a tough situation, right? If you get one bot in, you can kind of use them to help you. But you know, you're almost asking, how do you sell, right? How do you sell yourself in your you know, your wares? Different doctors have different personality types, want to get the information in different ways. So I have real trouble giving you kind of blanket advice. Some people want, you know, the facts, and you need to kind of identify those doctors where they actually want you to give them a page that shows you a couple of graphs of what the benefits are. Other doctors are, you know, chattier, and they want more of the patient's stories that go along with it. Others, you know, want you to be just very quick, concise, to the point with how you approach them. So it's a challenging question. I wish I could give you like a blanket answer for. You know, when you find an advocate that you click with, then really double down on that and kind of ask them to help you, you know, kind of pitch what you're doing to other physicians. I hope that's helpful. It's a tough, constant, ongoing battle though, for all of us, I think.
Would you prescribe pneumatic compression to a patient who had not seen a lymphedema therapist?
Oh, that's a great question. Yes. So, and I'll tell you the situation. My preference far and away is for the patient to go to the lymphedema therapist, though, so that they can learn the MLD, they can be evaluated, they can be educated. But there are situations in, you know, and again, where Vital brings us up. So, you know, we've got clinics in Alaska, right? We've got clinics in Maine where, the nearest center is 100 miles away, and it's just not possible for the patient to get in. So in those situations, I absolutely would prescribe a pump without them seeing the therapist. Again, it's not optimal, but it's certainly better than not treating them.
Here's one about, head and neck patients who are treated with radiation and chemo, but not surgery. When is it safe to start lymphedema treatment? Because if they develop lymphedema during treatment, our radoncs have been reluctant as they're concerned that since the cancer is not fully treated yet, maybe it would spread with MLD if we wait. And so they want to wait until treatment's completed.
Yeah. All right. So the answer to when you can start as soon as you're no longer in danger of breaking down the skin. So shortly after treatment. The question about spreading the cancer is kind of a silly one, in my opinion. When the surgeon goes in there, they're cutting and squeezing and bovying, and they're doing all sorts of havoc right where those cancers are to pull them out. So if cancer is ever going to spread, it's going to be when they are doing it. The lymphatic pump, cancer is getting into, if you have residual cancer, you're spilling those cells all the time anyway. The pump is not going to be responsible for spreading. The cancer spreads based on the biology of the cancer. So from my point of view, I think there's no real evidence for that. It's another kind of dogmatic thing, I think, that sounds good, but I don't think there's really any evidence. So if the radiation oncologist doesn't think their radiation has completely treated the cancer, then, where are we? That was like their treatment, right? So does that mean the patient can't move their neck because the forces they put on the lymphatic channels over there are going to spread the cancer? So anyway, my answer is as soon as you're no longer worried about the skin. And the other thing is, again, a slow, steady pressure problem that you're going to have.
How soon following a mastectomy or lumpectomy do you recommend an individual to begin therapy for optimal prevention of lymphedema?
Oh, before? Right. So I think the answer is, ideally in a prehab setting where you're educating them and giving exercises and teaching them self-MLD, right? And that can continue right after the treatment and indefinitely. And again, I think we're starting to see that these pumps are probably better earlier on, particularly in the high-risk patients who have positive lymph nodes.
Any suggestions on how to bring up lymphedema without completely scaring the patient? I recently had a patient sent for swelling post-breast mastectomy, and the patient said they'd never heard of this before by the surgeon. Yeah,
unfortunately, you just got to tackle it head on, right? There's no easy way to tell a patient they have cancer. There's no easy way to tell a patient they have lymphedema. So your answer is, look, I think you have lymphedema, but you know what? It's treatable. Here's what we're going to do, right? And be very, firm on the fact that you're going to help them maintain, improve their function and quality of life, and minimize the effect of lymphedema on their, function and quality of life.
Would Botox have any benefits with radiation fibrosis, particularly for the neck?
Yeah, great question. The answer is yes, I use it all the time. So kind of a funny little story for just, the 200 of us on the call here. For my rehab boards, they switched to these like quarterly little check your knowledge tests. And one of them was on treatment of radiation-induced cervical dystonia. So head and neck cancer patients who have neck spasms. And the question was, what is the first initial treatment? Is it therapy or is it Botox? And then a couple of other answers. And I actually put down Botox for the simple reason that in my experience, I send everybody to therapy, but frankly, the Botox for those patients who have painful neck spasms in the sternocleidomastoid and the scalenes has been incredibly effective. Of course, I missed the question and it had a reference and I was the reference. So I missed a question where I was the reference. I thought that was pretty funny. But the short answer to your question is all patients with cervical dystonia should have physical therapy, emphasizing manual techniques, myofascial release, postural retraining, all of those sort of standard things we do in them. But Botox into the SCM and scalenes is very easy to do, but not all physicians want to do it. It's very safe, very little issues at all that I get. Now, the corollaries in the back of the neck, don't Botox that. You're going to give people a dropped head syndrome. So, you stay clear of that, at all costs. The other place that I commonly do is the masseters for patients who have trismus. It's not going to open their mouth. But what it does is it takes away that component, that spasm component, So the PTs, OTs, and SLPs can get in there and do their manual therapies, their intraoral work, their stretching, and that rebound spasm of the masseter is not there. I can also do the medial and lateral pterygoids, but they're a little dicier to inject, so I don't recommend that. So anyway, thank you for a lowball question that I love to answer.
Well, I know that you have treated a lot of head and neck patients with the Flexitouch device. There's a question about, how does that external pressure of that Flexitouch impact the internal structures for those patients?
Yeah, it's all connected, right? So those lymphatics, even though, it's a network of lymphatics that are, so as soon as you're doing this external pressure and you're getting the lymph fluid to move, it's just by sort of osmosis, for lack of a better term, going to probably pull some of the lymphedema out of those other tissues. So even though it's very superficial, we're seeing, right, sort of secondhand. I don't know that we've actually shown the protein to move out of that, but we're seeing their swallowing get better. We're seeing their neck pain get better. We're seeing things that seem to be mediated by more internal structures getting better.
Does your team include dietitians and do the
Unfortunately,
dietitians?
no.
Oh, okay.
Yeah, I would love to have a dietitian. I mean, again, we're comprehensive, but I would like to be more comprehensive. So I would love to have a dietitian on the team. But again, remember, our team is well over 1,000 therapists now all over the country, but still no dietitians.
So I think we'll just take a few more questions here. Do you think providing massage, MLD, and myofascial release is helpful prior to radiation fibrosis forming?
Probably, right. I think, it becomes a question of how much time and treasure does the patient have to be able to get these things. But I think that any patient who's gotten, radiation, particularly for head and neck, is going to develop fibrosis. It's really just a matter of time, and that process probably starts almost immediately. So I think maintaining their range of motion, doing some of these techniques, giving them the exercises to do at home, probably would be preventative. Are we ever going to have a study to prove that? Probably not. But, logically, again, dogmatically, I would say it's probably a good thing. So if you have patients who you can do that on, I say knock yourself out. It's probably nothing but good for them.
So radiation fibrosis, have you seen any modalities from therapy be most beneficial in reducing that radiation fibrosis?
Yeah, our therapists are using I forget what it's called, little suction thing, a little suction device. It's kind of, lifting the skin, almost like a kinesiotape sort of thing, but I think more focal. They've really sworn by that. When I was at Sloan Kettering, they love these low-level lasers, which we don't have at any of our hospitals, to my knowledge. So these things are really just ways of kind of locally increasing perfusion, and they seem to help quite a bit with the fibrosis. Again, remember, the fibrosis, even though you're seeing it here and you can kind of break it up, it's still constantly wanting to form because of just the pathophysiology at the cellular level. But those two modalities, in addition to the manual techniques, the visceral techniques, myofascial release, have been anecdotally very useful. I'd love an actual study on them.
Have you heard of dry needling for radiation fibrosis?
Yeah, so I've done a lot of trigger points with bupivacaine in these groups, never steroids, and of course I do a lot of Botox in this group. Dry needling, I have mixed feelings on it. I know it's a thing some therapists do. The places you're doing it are places where you can be very close to causing a problem. I know that there's a fairly high incidence of pneumothoraces in therapists doing dry needling. So I'm not a huge fan of it because I don't think the effect is that great. And, I wouldn't want to see somebody doing it in the neck and causing a hemorrhage, right, on a head and neck cancer patient. So, yeah, I don't know. I don't do it. I do other things, but mostly the Botox. And when I'm doing the trigger point injections, just with an anesthetic, no steroid, it's usually in the back or the traps, things, that are fairly easy to do with very low risk of complications.
One says, I have a patient who has physicians who are telling her she no longer needs to avoid blood pressure readings on her arms. She has had axillary dissections on both. They're telling her that there's new research showing that it's no longer necessary to avoid those.
Yeah, that's kind of what we were saying before. It's doesn't seem, even though we've said it for years, that the pressure from the blood pressure cuff is really going to cause or worsen the lymphedema. So I understand that these are very firmly held beliefs by therapists who, gone through the training, and it's hard to undo it. I don't think it's such a big deal for that patient based on the literature. That being said, if the patient has a problem, then okay, but then where do we get our blood pressures on them? It also at some level becomes a practical thing. So doing a blood pressure on a leg, which I used to do all the time, is just not nearly as accurate or easy to do.
I'll do two more questions. One, I had a patient I treated for right breast lymphedema following lumpectomy as well as radiation. Our clinic had seen her intermittently following standard protocol. Approximately a year after receiving radiation or lumpectomy, she developed moderate severe hardening and fibrosis of her breast tissue. Is this common this far out from surgery?
Yep, that's the radiation fibrosis, right? Absolutely. So again, the gift that keeps on giving. So I've seen patients get this, 2 or 3 years later or 5 or 10 years later.
I will, let's see, the last question, and there's still a few here, but we'll end with this one. On trismus related question, is trismus irreversible? What successes have you seen with management of trismus, or is it reversible, I guess?
The answer is it depends on the patient. So the vast majority of my patients, I can improve trismus. So the improvement is manual techniques on the part of the therapist working with them. Sometimes the Botox won't make it better, but contributes, and then jaw stretching devices. So, there's Therabite, there's AuraStretch. My favorite is the Dynasplint, which is much more expensive, but it's a low load, prolonged stretch device as opposed to the others where it's like high torque and tends to cause a lot of rebound. So the important thing with trismus is when patients, they often will get it in the first year and then it kind of levels off and then it can come back later. When it comes back later, you're worried about osteonecrosis of the jaw, a tooth infection, tumor recurrence, those sorts of things that are causing it to happen now, which is almost always the case when you see it come on after that first year. So you rule that out, treat it, and then often you can get their mouths back open again.
Okay, well, I'm going to stop there. There are some other questions that we didn't get to, but I copied them and we will get back to with specific answers. And I will say thank you, Dr. Stubblefield, for such a great presentation. There was a lot of comments in the chat saying everyone really loved it. And for those of you who are interested in attending additional webinars in the future, here is our updated schedule, and you can go to tactilemedical.com/education to sign up for those. So thank you everyone for attending. And again, thank you, Dr. Stubblefield, for such a great presentation.
Thank you, I appreciate it. Bye everybody, have a good evening.